Hello and a very good day to everyone. So here we are again with our new RRR series, and this time we will be discussing mainly the flowcharts, tables, algorithms and important protocols in this series. So I'll be discussing today the module labor and delivery. So let's start. So the main topics in labor and delivery module, as we all know, is first of all a very important guideline, that is intrapartum care. Then comes fetal monitoring in labor. These two nice guidelines, as we all know, are extremely important to cover. Then come few of the GTGs of birth after previous cesarean section, assisted vaginal birth, breech and ECV, cord prolapse, shoulder dystocia, the NICE guideline of cesarean section, and the GTG of maternal collapse, of course. Now, the first table which we will be discussing here is pertaining to the stages of labor, the first stage and second stage. We all are well aware of what they mean. It is very important that we come to know about certain durations, because while answering the questions, we may be required to know and apply the exact durations which any primary or multi can spend in first stage and second stage. So these are the thresholds: 8 to 18 hours in first stage in primary and 5 to 12 hours in first stage in multi. Then the second stage. Now the second stage is sometimes very confusing. Why? Because second stage is often divided into passive and active. Now passive is when the lady is fully dilated, but only fully dilated. She is not pushing, the baby is not visible. But when the lady is fully dilated and starts pushing, involuntary pushing starts, the urge to push starts, and or the baby is visible on the perineum, then that second stage is termed as active second stage. Okay. One very important thing, that epidural, when the lady is on epidural, epidural will have an effect only on prolonging the passive second stage. Epidural or no epidural, the active stage will stay the same. If the lady is on epidural, the epidural have an effect only on prolongation of passive second stage in nulliparous as well as multiparous. Then there are a few things which we have to keep on observing at this frequency. Contractions, half hourly monitoring we have to do. BP, 4 hourly. Also respiratory rate, bladder care, these things have to be taken care of in the first stage. Pulse, hourly basis we have to monitor. In second stage, the frequency increases. Temperature, every 4 hours we have to take care and watch out for that. Vaginal examination we have to carry out 4 hourly in first stage and hourly in the second stage. Then comes very important FHR, that is fetal heart rate. We have to auscultate respectively. Here it is at least every 15 minutes and here it is at least every 5 minutes. So these durations are very important. We should take care of this. Then comes a very important document which has been recently introduced by WHO. Now instead of partogram definitely they can ask, but now what is being followed is WHO Labor Care Guide. Now this WHO Labor Care Guide, we should all know that this document is the WHO LCG and what are the components. Here a very important addition which they are now emphasizing is supportive care. So supportive care regarding baby, woman, the labor progress, which is the main part, cervix dilatation and descent. Then the medication and shared decision making. So we see that things like supportive care and shared decision making are being introduced in this WHO Labor Care Guide, and that's why it is slightly different from the routine partogram earlier which we were using. Now, another very important aspect is when we will suspect delay in first stage of labor and when we will confirm delay in the first stage of labor and what we have to do in what sequence. Now, this I have explained here with the means of an example. that suppose a lady is coming to you at 3 and she is 4 centimeter dilated. Now, after 4 hours, as we just saw, we have to perform a vaginal examination every 4 hours in first stage. After 4 hours, if her progress is less than 2 centimeter, okay, we have to see that the progress in centimeter should be half of how many hours have elapsed. So in 4 hours, the progress we expect that it should be at least 2 centimeter or more. Now, if it is not like that, for example, here the progress is just 1 centimeter, which is less than 2. So now here we need to label it as suspicion of delay. That is, we suspect delay. Now, immediately don't jump on to do amniotomy. First, assess all aspects like dilatation, descent, rotation, contractions. Discuss with the patient what she has, explain to her, discuss her whether support is there, pain relief is adequate or not. Then again reassess in 2 hours. Means after 7, you will at 7 you see that the progress, the delay, you suspect delay, you see all these aspects, then again reassess her at 9. Okay. Now examination after 2 hours reveal. Now in 2 hours, at least 1 centimeter progress should have been there. But if it is less than 1 centimeter progress, that is still she is 5 centimeters supposive. Then that means that we confirm that she is in delay and we diagnose delay. Now this is the time when we need to do amniotomy. So consider amniotomy and do it. Now, after amniotomy, again examine her after 2 hours, not after 4 hours. After amniotomy, we examine after 2 hours. If findings stay the same, that is again less than 1 centimeter progress. Now we have to see there must be some serious issue because delay is there. Contractions may be less. If it is yes, that contractions are less, we need to transfer her. We need to ensure that she's in obstetric-led care now. Up to here, the things can be handled in midwifery-led unit also. But if now we have to start her on syntocinon, prior to this, there are some prerequisites. We have to offer epidural. We have to put her on continuous CTG. So for this, she needs to be transferred to obstetric-led care. Now is the time when we have to start her on syntocinon. After starting syntocinon, we have to review after 4 hours. Unless some changes develop in FHR or contractions, we have to review her after 4 hours. In 4 hours, again, now this is 4. So the progress should be 2 centimeter, at least 2 centimeter or more from now. If it is less than 2 centimeter, then even after good contractions, then is the time that we need to assess her thoroughly. We need to escalate the things to the senior and consider her for a cesarean section. So hope this is clear. When we suspect delay, when we diagnose delay, when we do amniotomy, when we do syntocinon, start her on syntocinon, at what places, this should be clear to us. And when we have to take her up for cesarean section in view of delay in progress of first stage. Now let's focus on second stage. Second stage, as we already saw, passive second stage is full dilatation and active second stage is full dilatation along with pushing active efforts or the baby is visible. Now, as I told earlier, the epidural in place has got an effect just on the passive second stage, not on the active second stage. Epidural prolongs the passive second stage, maybe up to 2 hours max. Like minimum what it should be, it is not mentioned. But with epidural, maximum 2 hours we can allow her to stay fully dilated even without pushing. Now, this is the time duration when we will suspect delay, when we will diagnose delay in second stage of labor. Now, here it is different for nulliparous and multiparous. Just half an hour difference is there at this point of time. We have to conduct per vaginal examination after 1 hour of active pushing in nulliparous and after 30 minutes in multiparous. So let's have a look first at nulliparous. When nulliparous lady in second stage of labor starts pushing, we examine her after 1 hour. Now, after 1 hour, if the findings are the same, the progress is not good, then we suspect delay after 1 hour of active pushing in nulliparous. This is the time, if the findings are not favorable, progress is not good, we offer amniotomy, or if contractions are inadequate, we can offer syntocinon, and then again reassess in 1 hour. If again the findings stay the same, unfavorable, with inadequate progress, then is the time that we diagnose delay. So in nulliparous, after 2 hours of pushing, if the findings stay the same, then is the time we diagnose delay and take the decision of expedition of birth. That is, either if she meets the conditions for instrumental delivery, then we can do assisted vaginal birth, that is instrumental delivery, or if she is not favorable for application of instruments, then we should take her up for cesarean section and achieve birth within 3 hours of active pushing. Okay, so we have to take the decision of operative birth, either instrumental or cesarean, after 2 hours of active pushing and achieve birth within 3 hours of active pushing. Now this time duration is reduced in multiparous. After 30 minutes of active pushing in multiparous, we perform a vaginal examination. She hasn't delivered yet. So if the findings are unfavorable, we offer amniotomy or syntocinon, reassess her again after 30 minutes. That is, if at 8 a.m. she starts pushing, at 8:30 a.m. we examine, suspect delay. Again 9 a.m. we examine. If still the findings stay the same, at 9 a.m. we have to take the decision of operative birth. So here, operative birth is to be initiated after just 1 hour of active pushing, and birth is to be achieved within 2 hours of active pushing. So this is the time duration of when we suspect delay, when we diagnose delay in active second stage of labor in both nulliparous and multiparous. So here we see that whether she is on epidural or not, these durations stay the same. Epidural has just got an effect prior to this, that is on passive second stage. Now comes very important thing which we often tend to forget, which we often are confused about, that is the CTG readings. In CTG now, our life has become simpler, I would say, because this white, amber and red, we have to classify each of these features into white, amber and red, and then classify the whole CTG as normal, suspicious or pathological. Now, regarding contractions, contractions can be either white or amber. If less than 5 in 10 minutes, then it is white. If 5 or more in 10 minutes, then it is amber. Others can be white, amber or red. Baseline FHR, 110 to 160 is the normal, white. Now, apart from these apparent things that less than 110, between 100 to 109 will be amber, less than 100 will be red. More than 160, straight becomes red. Now, two more important things are there. If there is sudden rise in baseline by 20 beats per minute or more, remember here it is rise. Like earlier the baseline was 130. Now suddenly it has become 150 or more. Then that is a sign of hypoxia and we classify such CTGs into amber. Or we can't make out the baseline. Baseline is uncertain. Then also it's an amber feature. Okay. Then comes another important thing, that is variability. 5 to 25 is white. Less than 5, but just between 30 to 50 minutes is amber. More than 25, up to 10 minutes is amber. Beyond this, that is less than 5 for more than 50 minutes or more than 25 variability for more than 10 minutes is red. And another very important thing, sinusoidal is always straight red and take her up for category 1 cesarean section. Then very important and very confusing is deceleration. Now deceleration, as we all know, may be early variable or late. If there are no decelerations or early decelerations or just variable decelerations, not repetitive, without concerning characteristics, then it is white. Now, if there are repetitive variable decelerations with concerning characteristics, for less than 30 minutes, then it is amber. Or even if they are not repetitive, but with concerning characteristics, but for more than 30 minutes, then again it is amber. Now in late, if they are repetitive late decelerations for less than 30 minutes, then again it is amber. When these durations are exceeded, or there is acute bradycardia or single prolonged deceleration for 3 minutes or more, then it becomes straightforward red, and the NST, even one red, becomes pathological. So now how to categorize the whole of the CTG? Now each features we pick up, classify it into white, amber or red, and then classify whole of the CTG. If all are white, none of the feature is amber, it is normal CTG. Okay. If any one amber feature is there, then it is suspicious CTG. If two amber or any one red is there, then it is pathological CTG. So this is how we classify the CTG. Now the words like reassuring, non-reassuring are gone. Only normal, suspicious or pathological, NSP. Whole CTG will be classified as NSP, and each of the feature will be classified as WAR, white, amber or red. So how we have to make care decisions? Just a summary. However, it is very individualized decision. In each of the things, we will have to see whether the CTG is becoming suspicious or suspicious because of, if tachysystole means contractions are more, it is amber, we have to just remove the propes or reduce the syntocinon, stop the syntocinon. So the care will be individualized, but like an outline we can have through this. In normal, we will continue routine intrapartum care. If the CTG is suspicious but without any background risk factors, we fully assess, look for underlying reasons, and initiate the conservative measures like mobilization, left lateral position, oxygen, hydration, all these things. But if suspicious CTG is on the background of sepsis or meconium, then one additional thing which is mentioned in NICE is fetal scalp stimulation. So apart from conservative measures, we can also subject her to fetal scalp stimulation. If acceleration start coming, we get accelerations in response to fetal scalp stimulation, it is good. We can continue routine intrapartum care, but if not, then we have to expedite birth. Or if FSS is not considered feasible, if we can't do, then we can straight away expedite birth if no response to conservative measures. Otherwise, in pathological, we have to straightforward immediately initiate conservative measures. If no response, then straightforward expedite birth. Always exclude any acute event if the CTG is pathological, like it should not be cord prolapse, rupture uterus, abruption, sinusoidal CTG. All these are indications for immediate category 1 cesarean section. Now another important table is pertaining to instrumental delivery. We should know at what stations we term it as mid cavity, low and outlet. Rotation, non-rotational, this should be clear to us. If it is more than 45-degree rotation, that means it is rotational mid cavity or rotational low forceps. And another important thing is the place where we have to carry out the delivery. Now, if the chances of failure are very high, or if it is a difficult delivery, then it is preferred that we should give a trial in theatre. Mid cavity, always prefer to do it in theatre except multiparous occipito-anterior, that is non-rotational, which we can do in labor room. If suppose she has delivered vaginally earlier also, she is multiparous and rotation is not there, non-rotational occipito-anterior, chances of success of instrumental delivery is high, then we can definitely take her up for the same in the labor room itself. Otherwise, mid cavity, prefer to do it in theatre. Again, the classification, the same thing. Safety criteria, very important. Few things here, like we have to look. Whenever we are choosing the option of assisted vaginal birth, always read the question very carefully that all these criteria should be met. Head should be less than equal to 1/5 palpable per abdomen, either 0/5 or maximum 1/5, not more than that. Cervix should always be fully dilated. Station should be at level of ischial spines or below because high forceps no longer we apply. Caput and molding, remember, should not be more than 2 plus 2. Okay, if suppose all the things you seem it is favorable and caput and molding are too much, then also avoid. Pelvis should be adequate, and other than that, mother and staff should be adequately prepared with good analgesia in place, with adequate facilities and adequate backup plan. That's it. Look for these features in your scenario. If maternal BMI is more than 30, she's short-statured, effective estimated fetal weight is more than 4 kg or clinically big baby is there, head circumference is more, occipito-posterior or mid-pelvic birth, or when 1/5 of head is palpable per abdomen. In these cases, there are high chances of failure, so prefer to do your assisted vaginal delivery in the theatre. And try to choose options like trial of instrumental delivery in theatre. Now, other few important algorithms are for management of shoulder dystocia. We have to, first of all, in scenarios like these, look for the option call for help. If they haven't already mentioned that call for help, first go for this option. Then initiate Mac-Roberts maneuver, which should be the first one, 90% success rate. Along with that or after that, suprapubic pressure should also be there. After these two, if they are unsuccessful, then we have to consider episiotomy to make our internal maneuvers easier. Either delivery of the posterior arm or the internal rotation maneuvers like Rubin's wood screw. These all we have to try. If suppose she is multiparous or she is at home, then she can, before doing this, if she's with midwife can put her in all fours position or Gaskin's maneuver and try these again. Okay, and then these are second line. Mac-Roberts, suprapubic are first line. These two are second line, along with all fours position. And clidotomy, Zavanelli maneuver or symphysiotomy, that is the invasive things where we have almost lost the baby. These are the third line. Incident reporting is very important. Then comes cord prolapse. Now in cord prolapse, we need to look in the scenario whether she is at home or whether she is in midwifery led unit or whether she is in hospital. If she is at home, few things we have to take care that in which position she should be. If she is with midwife, bladder filling and all can be done. Now when she reaches hospital, what things we have to take care? We have to consider PV in labor. At every vaginal examination, we have to consider means rule out cord prolapse. Also, sometimes after leaking or spontaneous rupture of membranes or artificial rupture of membranes, it is mentioned that the heart rate is low or sudden decelerations develop. Then we have to immediately choose the option, do vaginal examination to rule out cord prolapse. Now, again, just like shoulder dystocia, this is also an emergency. Organize help first. Then if things like these are available, relieve pressure. Meanwhile, when we are taking the decision to shift her to OT, immediately if you are in hospital setup, listen to the heartbeat, whether baby is fine or not, and then take the decision of category 1 or category 2 cesarean section. Or if suppose labor is impending, means delivery is impending, we can facilitate it through instrumental delivery, things like that. Meanwhile, when these decisions are being taken, things which can be done are elevation of presenting part, either manually or through filling the bladder. Encourage into left lateral position with head down and pillow placed under left hip or knee chest position, and consider tocolysis. Then, of course, the definitive measure is birth, decision for birth. Emergency transfer to labor ward, assess and assist birth by quickest means. Urgency will depend on fetal heart rate, either category 1 or sometimes category 2. So consider category 1 with verbal consent within 30 minutes or less if suspicious or pathological FHR pattern. Category 2 with continuous assessment of fetal heart rate trace if fetal heart rate pattern seems to be normal. If it becomes abnormal, recategorize her to category 1. There should be minimal handling of loops of cord lying outside the vagina. While the lady is awaiting hospital transfer, advise her to assume this position, and during transfer, exaggerated Sims position. Now, another important thing is cesarean section category. Category 1 means immediate threat to life of either mother or baby. So it has to be done real fast within 30 minutes. Indications are like abruption, acute events, abruption, rupture, cord prolapse, actively bleeding placenta previa, intrapartum hemorrhage, presumed fetal compromise with severely abnormal CTG, okay, severely abnormal. For example, sinusoidal or prolonged bradycardia. Otherwise, if compromise is there, fetal distress is there, but it's not life-threatening, so we can take some advantage, means within 75 minutes, we can do cesarean. So like all other cases in labor, breach in labor, failure to progress, grow in labor, pathological or suspicious CTG, all these are category 2. In category 3, there is no compromise, but she needs delivery, like failed induction, or if she posted for elective cesarean section with spontaneous rupture of membranes. All these are category 3. And category 4 are all elective, means the time making decision depends on the patient or doctor. So any time of making decision, like cesarean section on maternal request, previous cesarean not in labor but negative consent for feedback, or any elective case. This is category 4. Now, another important aspect is management of second twin. So top up epidural, site IV infusion, syntocinon, keep it ready for second stage, and deliver twin 1 as if singleton. Make note of time. Now check lie and fetal heart rate of the second twin. Use ultrasound if necessary or if any doubts are there. And you can put CTG of twin 2. Now here mainly it is emphasized if suppose twin 2 isn't transverse lie. First thing what we have to do, we have to look for feasibility of ECV. Okay, if ECV is feasible, perform it without delay. Now there may be two possibilities. If ECV is successful, then perform artificial rupture of membranes. If we find that there is delay or any signs of fetal distress, then use ventouse. This is one specific indication where ventouse seems to be favorable. Size 4 cup ventouse delivery. If there is no fetal distress or delay, we can just await for normal vaginal delivery. Now, if the fetus is in transverse lie, we performed ECV, but it was unsuccessful. Or if ECV was not feasible, membranes ruptured, then we can perform internal podalic version and breech extraction. Okay, so that's the management of second twin. Again, very important. So hope these few tips and tricks and flowcharts, algorithms, tables and protocols related to labor and delivery module were useful for all of you. Revise and do your best in the exams. One very important tip is read the question very carefully and underline or keep all the important aspects in your mind. So all the best for your exams. Thank you. Bye-bye.